In this video, I'm going to talk about different esophageal disorders, starting with the esophageal cancer, achalasia, diffuse esophageal spasm, esophageal hiatal hernias, Mallory-Weiss and Boerhaave syndrome, Plummer-Vinson syndrome, Schatzki ring, as well as esophageal diverticula. So starting with the esophageal cancer, there are two types of esophageal cancer: squamous cell carcinoma, which is the most common type of esophageal cancer worldwide, and it affects the upper as well as mid 1/3 of the esophagus. So in the US, squamous cell carcinoma used to be the most common type, but for the past few decades, since there was more incidence of obesity, which is a risk factor to the adenocarcinoma is the most common type of esophageal cancer in USA. But the squamous cell carcinoma remains the most common cause of esophageal cancer worldwide. And the risk factors to squamous cell carcinoma include the smoking, alcohol, nitrosamines, which are found in the smoked foods, hot beverages, as well as hot foods, human papillomavirus, as well as the achalasia. And then we have adenocarcinoma, which is the most common type of esophageal cancer in the USA. Risk factors include obesity, gastroesophageal reflux disease, as well as Barrett's esophagus. So gastroesophageal reflux disease is what leads to the Barrett's esophagus, where the esophagus will undergo metaplasia. So the cells in the stomach are columnar cells, which are specialized for tolerating the stomach acid. The cells in the esophagus, however, are squamous. So once there is an acid reflux and the acid keeps on hitting the squamous cells inside the esophagus, they will undergo metaplasia and will turn into the columnar cells so that they would be able to tolerate the stomach acid. So here is an example of the Barrett's esophagus, where you can see that there are squamous cells on this side, but then the other side, the left side of image, has undergone metaplasia and has formed columnar cells. And then the clinical presentations of these patients include dysphagia, where they will have initially difficulty with swallowing solid foods that will later on become problem drinking liquids as well. So these patients have more problem with eating solids, but then later on in the course of the disease, they will also develop problem with drinking liquids as well. They also develop weight loss as well as pain with swallowing. The next disorder is achalasia, which is a motor disorder of the smooth muscles of the esophagus. And there are two presentations associated with achalasia. One, the lower esophageal sphincter fails to relax in these patients, and that is due to the loss of the Auerbach, also known as myenteric plexus. So here you can see that the lower esophageal sphincter fails to relax. And then there is also abnormal peristalsis of the esophageal body. And so unlike esophageal cancer, where patients had more difficulty with solids compared to the liquids, patients with achalasia will have equally difficulty with eating solid food as well as liquids. And then one risk factor to the development of achalasia is infection with the Trypanosoma cruzi, which causes the Chagas disease. And so these patients, since there would be antibodies that are directed against the myenteric plexus, will develop achalasia. Other features of Chagas disease include cardiomegaly as well as toxic megacolon. So the way I memorize features of Chagas disease is that it causes megaesophagus, megaheart, as well as megacolon. So it causes achalasia, cardiomegaly, and toxic megacolon, are all caused by the Chagas disease, which is caused by the Trypanosoma cruzi infection. Now, achalasia itself, as I just discussed earlier, can also lead to the development of the squamous cell carcinoma of the esophagus. For the diagnosis of these patients, you can order the barium swallow, which will show Baird's beak. So here, as you can see, if here is the head of the bird, then we have the beak, which is the narrowing right here, where there is a lower esophageal sphincter which fails to relax. And then one other test that you can order is the manometry, which will show that one, there is failure of the relaxation of the lower esophageal sphincter, and there is also a peristalsis of the esophageal body. And then for the treatment of these patients, you can perform myotomy, balloon dilation, as well as the Botox injection inside the lower esophageal sphincter to help it relax. The next condition is the diffuse esophageal spasm, which is caused by non-peristaltic, spontaneous as well as repetitive contractions of the esophageal body, but there is a normal function of the lower esophageal sphincter. So unlike the achalasia, these patients will have a normal dilation of the lower esophageal sphincter. And so this pattern of the spasm will give it a corkscrew appearance on the barium swallow. So here you can see that there is a corkscrew appearance of the esophagus on the barium swallow. And so presentations of diffuse esophageal spasm is a non-cardiac chest pain that has a similar presentation to the angina, and there is also dysphagia that is associated with this condition. For the diagnosis, you can order the barium swallow, which again will show you cork screw esophagus, and then you can also order manometry, which will show a multiphasic repetitive contractions that occur after a swallow. And then for the treatment, you can provide these patients with nitrates or calcium channel blockers. So you may recall that I've mentioned that for patients that have Prince metal angina, where there is contractions of the smooth muscles of coronary arteries, these patients are being treated with nitrates and calcium channel blockers. So similarly here with this disorder, due to the contractions of the smooth muscles of the esophagus, we will treat them with the same medications, which include nitrates and calcium channel blockers. Next, we have the esophageal hiatal hernias, which are divided into sliding and paraesophageal hernias. So here you can see that we have the gastroesophageal junction, and with these sliding hernias, the gastroesophageal junction has moved into the thorax, and part of the stomach also has been moved into the stomach. Versus with the paraesophageal hernias, the gastroesophageal junction has not been moved, so it's still under the diaphragm. But still, part of the stomach has herniated into the thorax. So with the first condition, there is an increased risk of GERD, which can lead to the metaplasia, and thus it can cause Barrett's esophagus and increase the risk of adenocarcinoma. While with the paraesophageal hernia, there is a risk of strangulation since part of the stomach is being stuck in the thorax area. So first condition is sliding esophageal hernia, which accounts for more than 90% of the cases of esophageal hernia. The gastroesophageal junction and a portion of the stomach in these patients has herniated into the thorax through the esophageal hiatus. And so presentations of these patients include heartburns, chest pain, as well as Barrett's esophagus, which increases the risk of adenocarcinoma. So for the treatment, you can provide these patients with antacids, ask them to elevate their heads after meals, eat small meals rather than large meals that can enhance the chance of acid reflux, and then finally you can perform the procedure Nissen's fundoplication. Paraesophageal hernia is the next condition, which accounts for less than 5% of the cases of esophageal hernia, and in this condition the gastroesophageal junction remains under the diaphragm, while it's the stomach that herniates through the thorax. So part of the stomach has been herniated, as a consequence of which there is a risk of obstruction, incarceration, as well as strangulation. And so these patients must be treated with surgical correction. Mallory-Weiss and Boerhaave syndrome are next, both of which are caused by binge drinking in alcoholics. And so with the Mallory-Weiss syndrome, there is a mucosal tear at the gastroesophageal junction, and this is due to the forceful vomiting or retching that is again seen with binge alcohol drinking. And with the Boerhaave syndrome, the forceful vomiting that is associated with binge drinking of the alcohol, or in patients with bulimia, also this condition is seen, can lead to esophageal perforation. And so patients with Boerhaave syndrome generally present with pain, tachycardia, hypotension, as well as increased respiratory rate. And once you obtain an X-ray of these patients, so chest X-ray will show you air in the mediastinum. The next condition is Plummer-Vinson Syndrome, which presents with upper esophageal webs. So here on endoscopy, you can see the web that is shown right here. And here on barium solo, again, you can see that there is a web right there. And these patients present with the triad of the dysphagia, iron deficiency anemia. They also present with spoon-shaped fingernails. And then finally, cervical esophageal webs, which is shown here on these two images. And then Schatzki ring is a lower esophageal web that is always accompanied by sliding hiatal hernias. And then the final condition is the esophageal diverticula, which are divided into Zenker's diverticulum, traction diverticulum, as well as epiphrenic diverticulum. So first, starting with the Zenker's diverticulum, this type of diverticulum is the most common type and affects the upper 1/3 of the esophagus, and the reason it's caused is due to the failure of the cricopharyngeal muscle to relax during swallowing, as a consequence of which there would be increased intraluminal pressure, and so therefore there would be an outpouching of the mucosa through the pharyngeal constrictors. And so presentations of these patients include dysphagia, regurgitation, halitosis or bad breath, as well as chronic cough. And for the treatment, you can perform the cricopharyngeal myotomy. The next form of diverticula is traction diverticula, which is in the midpoint of the esophagus. And then finally, we have the epiphrenic diverticula, which is in the lower 1/3 of the esophagus, and this type of diverticula is associated with esophageal dysmotility or achalasia. And that concludes our discussion of the esophageal disorders.